I'd now like to hand over to our next speaker, Associate Professor Marion Harris. Thanks, Marion.
Good afternoon, everyone. I'll just kick straight into my slides. There's going to be a little bit of repetition, but not too much. So as Megan touched on, there are different cells in the ovary that can become malignant, and we focus on the epithelial ovarian cancer that makes up the majority. There is a subgroup of these type of cancers that include borderline ovarian tumours, and these have low but not zero malignant potential, meaning ability to invade and spread. And we'll talk about later that while epithelial ovarian cancer is associated with a higher risk of hereditary predisposition, the borderline ovarian tumours are less associated, particularly with BRCA1 or 2 gene changes. As Megan said, different type of ovarian cancer is a cancer that arises in the germ cell. They're the egg cells of the ovaries. And then similarly, the sex cord tumours of the ovary, basically the connective tissue of the ovary, that give rise to different types of tumours. And these latter two, the germ cell and the sex cord tumours of the ovary, are less associated with hereditary predispositions. Also, as Megan touched on, within the epithelial ovarian cancer groups, there are some different types of histologies, or the appearance that the pathologist can see under the microscope. And the most common is referred to as the high-grade serous, and that's the cells have a certain appearance under the microscope, and that's the commonest type. And then there's the mucinous ovarian cancer, where the goblet, the mucin droplets can be seen in the cells. Then there are clear cells, which also have a different appearance to the pathologist's eye, and then also the endometrioid. So they're the commonest types of epithelial ovarian cancer. And sometimes they can be mixed, so a combined endometrioid and clear cell, or serous with a touch of clear cell. So with genetic testing, we often talk in clinic about germline genetic testing, and that's when we're trying to test the cells, usually from the blood, but they can be from the skin. These genetic changes are thought to be representative of the genetic makeup of all the cells in the body, and that therefore includes the egg cells and the sperm in the gonads that could be transmitted on to the next generation. And just to draw a difference, increasingly in this day and age, people are having tumour cell testing, which is often called somatic genetic testing, whereby the tumour testing is tested. So it's just important to draw that difference. And so mainly when we're talking about genetic testing in familial cancer clinics, we're talking about germline genetic testing, whereas in oncology clinics, they're often more focused about tumour testing, perhaps particularly with some other, tumour types like lung or colorectal. So a mutation, as we've heard, is an alteration or change in the DNA. So when we do genetic testing, we're trying to see if we can identify any disease-causing mutations that would produce an altered protein or lack of protein. And as we've heard, increasingly as more and more genetic testing is undertaken, we sometimes increasingly find a gene change of uncertain significance when we're not sure if it affects the protein and therefore whether it affects the health of the person or the gene product that's made. So increasingly, we have to look at ways of how that's going to be sorted out. So I'm going to go through these conditions one at a time. So I just wanted to list them. So up the top, BRCA breast ovary cancer syndrome was the main focus of our attention in ovarian cancer until the last few years. Lynch syndrome, we've heard, is associated with colorectal and uterine cancer and sometimes ovarian cancer. We'll touch on some newer genes that have really only been in this space and certainly in the genetic testing space in the last few years, RAD51C and D, and then some other mutations. So I'll go through them one at a time. So breast cancer gene 1 and breast cancer gene 2, sometimes called BRCA1 and BRCA2, they're DNA damage repair genes. So the cells in our bodies are replicating their DNA often. And when in that process where 30,000 genes are being copied, errors can be made. So having a repair mechanism to correct that's very important. So if this is faulty, this can be an important cause of genetic alterations. As you've heard, in these conditions, move in steps. When you have a hereditary predisposition, one copy of, say, your BRCA1 is already altered, you start from a higher point up that staircase. With BRCA1 and 2 gene changes, we generally say in our community, we think about 1 in 400 people might carry this gene change. We know that in the Ashkenazi Jewish population, the chances of any random person carrying a BRCA1 or 2 gene change is much higher, about 2.5% or 1 in 40. And there are so-called founder or commonly found changes in people of certain ethnicities. So in particular, there might be Indian founder mutations or Dutch founder mutations, and also Iceland. Not that we see many Icelandic people here in Australia, but it's a big thing in Iceland. So those who carry a BRCA1 or 2 gene change, if they're female, are said to have up to a 7 in 10 or 70% lifetime risk of developing breast cancer and up to a 50% lifetime risk of developing epithelial ovarian cancer. That's most commonly high-grade serous cancer. And the average age of diagnosis is approximately in the 50s. With a BRCA2 gene change, once again, the lifetime risk of breast cancer in a recent series was the same as BRCA1, so 70%, but the ovarian cancer risk is lower, around a 10 to 20% lifetime risk. But the average age of diagnosis is a bit older, in the later 50s. As I mentioned, most of the tumours associated with these are high-grade serous, but also can be endometrioid or clear cell cancer. And typically, BRCA mutations are not found in the lower-grade serous adenocarcinoma of the ovary or the so-called borderline ovarian tumour that are more usually confined to the ovary and have a lower risk of becoming invasive and spreading outside the ovary. And also in the mucinous adenocarcinoma of the ovary, BRCA mutations are seldom found. And so those subtypes of ovarian cancer would not routinely be offered BRCA1 or 2 gene changes because of that reason. So what are some of the indicators that we look at when we're wondering, could someone with ovarian cancer have a BRCA mutation? So we'd always look, does that person now with ovarian cancer have a personal history of breast cancer, or is there a family history of either breast or ovarian cancer? Looking at the close relatives, the first or second degree relatives. And the breast cancer we might see in BRCA families is classically a high-grade triple-negative breast cancer, or one that occurs at a younger age, or someone might have had bilateral, both-sided breast cancer. With the family history, as we said, we're looking for any types of epithelial ovarian cancer, especially serous. We're looking to know that person's ethnicity, so any particularly Jewish ancestry. In men, BRCA gene changes associated with an increased risk of prostate cancer, especially BRCA2, and that's classically high grade, so we're also interested in that. Individuals with BRCA2 gene changes do have some increased lifetime risk of developing pancreatic cancer, around the order of 5%, so always looking in a family tree, is there any personal or family history of that? With respect to age at diagnosis of ovarian cancer, the literature shows us that the chances of finding a BRCA gene change are rarer in certain age groups, and that includes the very young. So as soon as you see someone who's had epithelial ovarian cancer diagnosed under 30, we know the chances of finding a gene change are lower than if they were diagnosed, say, in the 50s or 60s. And similarly, as you get to an older age group, over 70s, the chances of any one person with epithelial ovarian cancer having a BRCA mutation are lower. So generally, and particularly because ovarian cancer types can be mixed and sometimes can be hard for pathologists to accurately tell, is there any serous component to that clear cell or endometrioid tumour, all invasive epithelial adenocarcinomas of the ovary that are not mucinous and not borderline are generally offered BRCA genetic testing.
And sometimes some groups apply an age limit, so only do under 70. But I think increasingly with gene panels testing being cheaper, the idea is just to spread the net.
So when we offer a woman with ovarian cancer genetic testing, we're doing it because we're interested in optimising any therapy options for the treatment of that ovarian cancer And in particular, it's recognised that if someone carries a germline BRCA mutation, their disease can be especially responsive to so-called PARP inhibitors. So these are a type of therapy. PARP is just an enzyme. I've given you the name there, poly-ADP ribopolymerase. It's an enzyme involved in DNA repair. So in individuals with a BRCA mutation, double-strand DNA repair is defective in the tumour. So if then this targeted therapy inhibits single-strand DNA repair, this is a lethal hit to cancer cells, and yet normal body tissues still have that functioning BRCA, one copy of the BRCA that's functioning well, so they tend to be relatively resistant. And the good thing about PARP inhibitors is that they're oral, they have lower toxicity than standard chemotherapy, and so currently these drugs are PBS, so reimbursed by our system in the maintenance therapy for those who've had relapsed ovarian cancer, who re-respond to platinum chemotherapy and who have a germline BRCA mutation, and they're indicated in that maintenance phase to increase the time until there's any evidence of further disease activity. And the PARP inhibitor mainly used in Australia is called olaparib. Olaparib, the PARP inhibitor, can also be used as a single agent down the track in third or more line therapies. And typically we know that if someone does carry a BRCA mutation, they're often very treatment responsive and respond very well sometimes to multiple lines of retreatment with platinum therapy that can in some cases go on for a number of years. So it tends to be viewed as a favourable prognostic factor, and that they may be, but not always, be long-term responders to treatment. Of course, if the individual with ovarian cancer does have a BRCA mutation, there is some increased risk of breast cancer, and depending on how their ovarian cancer treatment is going, that may or may not be so relevant. When we offer a woman with ovarian cancer genetic testing, we're also focused on her family members. So there's then, if a gene change has been identified that's disease-causing, then predictive genetic testing can be offered to unaffected relatives, whether they're male or female. And for affected female carriers, there's the option of having surgery to remove the ovaries and tubes. That's called bilateral, both-sided salpingo ovarectomy, removal of the tubes and ovaries. And this is recommended for female BRCA1 carriers by 40 and by 45 in BRCA2 carriers. And that's just because the age at which the ovarian cancer risk increases is different in the two genes. Usually there's no need to remove the uterus, but that is sometimes undertaken for different reasons. And there's always a small risk of a so-called primary peritoneal cancer. You know, the cells that occur in the ovary line the peritoneum, and so can't always be completely removed. And these women also have a breast cancer risk, so they can look at MRI surveillance, preventive mastectomies or use of tamoxifen. And for men, it's the ability to pass the gene change onto their daughters, but also particularly with BRCA2 an increased risk of prostate cancer, and screening options are available for that. So I'm just going to move on through this, but depending different chances of there being a BRCA mutation. And generally this varies from sort of 13% up to about 20%. So I've just listed some figures here from one series, so suggesting that around at least 13% of all epithelial ovarian cancers carry a BRCA mutation. They're saying 15% for primary peritoneal, a little bit higher for the fallopian tube cancer at 20%. High-grade serous, a higher rate, so dropping down with the clear cell, less likely, especially if it is really a pure clear cell adenocarcinoma of the ovary, a lower chance of finding mutation, but there may be a mixed serous component. Endometrioid cancer, a little bit higher. So we're interested in high-grade epithelial ovarian cancer, there'll be a high mutation rate. As soon as it becomes low-grade, the chance for mutation are much less. Just jumping back to Lynch syndrome, which is usually a hereditary colorectal and endometrial syndrome, where ovarian cancer, I've listed some figures for you there. The risk for there are 5 genes that commonly cause Lynch syndrome. So for MLH1 gene carriers, the lifetime risk of ovarian cancer with their females around 10%. So By contrast, the colorectal cancer risk is much higher, and so is the uterine cancer risk. So ovarian cancer is less of a feature in this condition, but still can be a part of it. And the type of ovarian cancer people with Lynch syndrome get are a bit different. They're more of the mucinous endometrioid clear cell and less of the serous type. And another feature of Lynch-associated ovarian cancer is it usually occurs before the age of 50. So in Victoria, when most women with epithelial ovarian cancer access BRCA testing, we would always routinely test mismatch repair genes in most centres in Victoria undertaken where that ovarian cancer was diagnosed. The current cutoff we use is less than 60. For other tumours like a borderline ovarian tumour, it's not routine that they would always be screened for Lynch syndrome, but I think the family history would always be taken and it would be considered, particularly if someone with a borderline tumour or a primary mucinous adenocarcinoma had a sibling, say, that had colorectal cancer. So I think that's more take the family history rather than being absolutely routine. So there are management options if someone has Lynch syndrome and has epithelial ovarian cancer. These tumours, by nature of their exact type of genetic alteration, are called microsatellite unstable. That just means there's so many DNA repair errors, there's a lot of genetic variation, and these tumours often respond to immunotherapy. And so this is a therapy option that you'd consider if you knew that someone had a Lynch syndrome-associated epithelial ovarian cancer. Immunotherapies are generally being explored for all women with epithelial ovarian cancer, but it's a special consideration if we knew that someone has Lynch syndrome. And of course, for the individual and their family members who, if they have Lynch syndrome, there's the option of predictive testing and then offering colorectal cancer screening to family members, as well as thinking about the individual in front of you. Of course, the management of their ovarian cancer would take precedence, and so doing colonoscopy may not be appropriate. I've jumped ahead. So the issue about whether family members, the colonoscopy, and if they're female, increasingly some women who carry a Lynch syndrome mutation elect to have, usually in their mid-40s, to have a preventive hysterectomy and salpingo-oophorectomy, removal of ovaries and tubes, to reduce the risk of both endometrial and ovarian cancer. And just to contrast that with the BRCA carriers in whom the uterus is usually but not always left. So just jumping on, increasingly in the last years, other hereditary predispositions to ovarian cancer are being considered more routinely in clinic. Now, particularly, I just mentioned before these genes called RAD51C and D, and another gene called BRIP. These are inherited in the same way as BRCA1 and 2 gene changes. They're also involved in DNA repair. The lifetime risk of ovarian cancer is said to be in the order of 5 to 10%, so more along the lines of BRCA2 than the higher risk, 50% lifetime risk with BRCA1. The breast cancer risk is yet to be established, some studies suggesting the breast cancer risk is increased and others being less certain, thinking they're more ovarian risk genes. So people who carry these gene changes, particularly for their relatives who might be found to carry the gene change after, say, their sister's been diagnosed, these people are suggested to consider having preventive bilateral salpingo-oophorectomy, removal of the ovaries and tubes, at around age 45 to 50. So the age of onset of ovarian cancer in these conditions is thought to be later than occurs in the BRCA1 and 2. And because these are new, we are learning more about them all the time. I just want to mention some other genes so increasingly now we have these gene panels. They're cheaper. We can test for multiple genes at a fraction of the cost that it used to cost to test for just BRCA1 on their own. Other genes that in series of women with ovarian cancer have been found include these genes called CHEK2 and ATN. These are different genes that are thought to have some increased moderate risk breast cancer genes, but they are found in some studies to be quite prevalent in people who have had ovarian cancer. So I think there's a lot that's still being worked out and determined, and there's a lot of things that are unclear. So I think this is a very active area and more studies over time. Just going to mention, I've listed there a few other genes that are mentioned, PALB2, BARD, things that are really still being associated but possibly carry some increased risk of ovarian cancer. I was just going to have a summary slide. So all non-mucinous, non-borderline ovarian cancers diagnosed, I'd say, at any age, but especially under 70, should have BRCA1 and 2 genetic testing. With the cancer gene panels, most ovarian cancer diagnoses diagnosed under 60 really should also be tested for the Lynch Syndrome, which was the mismatch repair genetic testing as well. I'd say the chances of, if we don't find a BRCA1 or 2 or a Lynch Syndrome gene change, the chances of these other RAD51C and D is much less likely, but I suppose that in an ideal world, you would test for them all so that you could say you've had BRCA1 and 2, you've had mismatch repair, you've had BRIP, RAD51C and D. Truly, that's as most as we can currently test, and if we've excluded all of those to the best of our ability, we're into the sort of research box about it's either not hereditary, it's either occurred as a one-off, or is it something yet to be determined or worked out. So just to clarify, the borderline or low-grade epithelial ovarian cancer, clear cell endometrioid, primary mucinous, consider Lynch syndrome, and screening for Lynch syndrome can either be done by genetic testing or an immunohistochemistry test on the tumour tissue looking for a missing protein. I did just want to mention there are some other rare hereditary conditions associated with other types of ovarian cancer, but I only just want to mention them in passing because they're really very rare. So in a hereditary bowel condition called Poitts-Jaeger syndrome, it's a bowel polyposis syndrome, ovarian stromal tumours, so tumours of the connective tissue of the ovary, can be associated. And there is a rare type of a small cell that's a neuroendocrine type carcinoma of the ovary where there's an elevated calcium. There's also an underlying hereditary predisposition. I was going to just finish by showing a recent case series that was published a year ago, and they were about 4,500 women with epithelial ovarian cancer had multi-gene panel germline testing of 32 genes. Now in this series, overall 13% had a mutation, a disease-causing gene change detected. So that was a bit lower than expected. It could have come up as high as 20%, so it's going to vary according to the types of ovarian cancer in the group. 25% had a variant of uncertain significance, and generally when that happens, ideally those variants are followed, and hopefully the idea is that over time those variants will be reclassified, and many of them will perhaps be found not to be significant, but a small number of them might turn out to be disease-causing gene changes. So out of the group, 52% had a so-called negative or uninformative test. In this group, the median age of the cancer was around 59, 60, which is typical. About 20% had a family history of ovarian cancer, 13% had a history of prior breast cancer, and of the gene disease-causing mutations found, over half had BRCA1 and 2 gene change, so that's where the main money was. In this series, so 10% had these CHEK2 and 6% these ATM gene changes, which we're really not quite sure what to make of. We're more aware of those genes being involved in moderate breast cancer risk. And then 10 or 15% had a combination of these other rarer gene changes that I mentioned, the BRIP, the RAD51C and D, and then about 10% the mismatch repair genes. So that's just to give you an idea if you had a big group of women with ovarian cancer, organising genetic testing, perhaps what you're likely to find. And so perhaps I'll leave it there and pass it back to Vanessa.
Great. Thank you very much, Marion, for providing us with all that valuable information. We have had quite a few questions come through. Unfortunately, we've only got time for a couple. So I will just get onto the first one. One of my daughters had borderline cancer at age 23 and again this year at 27. Do you recommend that my other two daughters get genetic testing?
So look, the borderline ovarian tumours, my understanding is they can be recurrent. So I think the fact of the recurrence doesn't make me think of like a separate primary. We do know some of these can occur in younger women. I would say generally what we do is take an assessment of the family history. So I'd be interested to know if there was any other family history of, like I said, bowel or uterine. So we wouldn't normally do BRCA1 or 2 gene testing, but we may consider testing for Lynch syndrome. So I think if there's no family history of any cancer at all, we may not do it. On the other hand, the only thing I would think of is doing a screening test for Lynch syndrome, but most likely that is a one-off and then sort of a recurrence of the original tumour pathology with that second episode at 27. So if she wanted, I think she could seek a referral to her FCC for them to explore the family history and just go through with that, but it may well be just a one-off if there is no family history.
Okay, great. Thank you. Next question is, I would like to know what treatment is available for the TP53 gene.
So we haven't mentioned P53 is another germline change that classically causes a condition called Lynch syndrome or breast sarcoma. Rarely, ovarian cancer can be part of that. Unfortunately, there's no real. And the other thing I wanted to clarify is many cancers, whether they're lung or colorectal or ovary, would have a P53 gene change in the actual tumour tissue, but that's quite different to being like in the germline. So P53 is very commonly altered in many cancers. So generally those tumours are not treated any different, and we don't have any therapy to correct the P53 defect at a germline. So unfortunately, if someone does carry a P53 gene change, we just have surveillance regimens that focus on like breast MRI and whole body MRI. So there's no direct targeted gene therapy at present, but I suppose it remains a dream, particularly for people with germline P53 gene changes.
Okay, thank you. And we'll just ask one more thing. There are so many questions coming through. How does the location of the fault in the gene affect the risk?
If the gene change particularly occurs in certain parts of, say, BRCA1 or 2, we can know that that's particularly associated with a higher risk, say, of ovarian cancer, and that a gene change outside those ovarian cluster areas, the risk might be a bit lower. But overall, we wouldn't rely on that too much to alter what we do and what we say to a family. So while there are different risks, and for example, certain genetic alterations often say a large deletion where there's a large portion of, say, the BRCA1 or 2 deleted, we know that can correlate sometimes with really strong family history. So young age onset of breast cancer, very high chance of someone being affected, say, at a young age or having bilateral breast cancer. So a very strong family history. We do know, we take note of certain gene changes as being sometimes very risky, say for people that have it, and others that don't seem to be acting as strongly as we'd expect. So there is certainly a correlation, but generally we treat most people and give advice similarly, irrespective of where. If it's a disease-causing alteration in BRCA1, our advice is usually going to be the same. Look at breast risk, look at ovarian cancer risk.
Right. Okay. Well, thank you very much, Marion. I know you stepped out of the clinic to present this, to do your presentation, so I will let you go. So thank you very much again. We really appreciate your time and all the information you've shared with us.